And just a second. I'll make you
I
as a
can share
host.
from my phone.
You can share. Make host. Yeah, you can share your slide.
One second. Not used to doing this on the phone, but it's not letting me share the slide I've prepared on the phone. Doesn't matter. Shall I just tell the scenarios and we can discuss
Yeah,
it?
that's okay. No problem. Yeah. Anyone wants to take up, or can I take? Go ahead, Prashant.
Yeah, I mean, is it
Okay.
on liver transplant, Senthil?
I just prepared very basic transplant scenarios just based on one is liver transplant, one is the brainstem death and confirmation, stuff like that, and one is the vascular access, basically renal transplant. So
I
I
can
just
take
prepared
one.
very basic. Yeah. Just for the sake of discussion and more in terms of not going into detail of stuff, but at least what questions I just saw from our FRCS prep books and companion series and just tried to prepare some stuff.
Thanks, Sunil. Prashant, you want to take up, or?
Yeah, let's do it.
Yeah, go ahead.
Okay. So first scenario, where am I? Can you guys see me? Yeah. Let me just try sharing once more. Nah,
Senthil,
let's forget it. Sorry?
Short case or?
Yeah. Just short, not even short case, just the 5-minute clinical, the Viva scenarios. I thought so, not a case discussion.
Okay.
The ones you were mentioning, 5 minutes and questions. So, right, first scenario is a 65-year-old male post lap right nephrectomy for renal cell carcinoma 6 years ago. Now has an EGFR of 12%, which is CKD stage 5. And he's referred by the nephrologist to your clinic for future renal supportive management and discussion in the clinic regarding treatment options. So how will you proceed?
Okay. So I haven't studied renal transplant and access, but I'll still give it a go. So this patient has had a previous nephrectomy, and now his EGFR is less than 12. So he will obviously need renal support to maintain his electrolytes status and homeostasis. So he will need a vascular access, and this patient. The choice for vascular access will depend on his comorbidities, whether he's got any diabetes, blood pressure, if he's got any a significant medical history and surgical history, and I'll also need to know which is his dominant hand, and will need to do a duplex of his non-dominant hand to see where we can place the vascular dialysis access.
Yes, that's right. So it's basically the approach. The questions: what is your preferred vascular access? What are the options?
Okay, so the preferred vascular access would be on the non-dominant hand, provided he's got a patent arterial and a venous system. This has to be my preference would be to place this vascular access as distal as possible, so it would be in the snuff box, and the diameter of the artery and vein should be more than 3 millimeter in size, along with a patent artery with no atherosclerosis. However, if this patient is diabetic, or if there are any atherosclerotic plaques, or if there is a compromised arterial supply to the hand, then I would like to place this access much more proximally, and that would be in the brachial fossa.
Okay. Could you tell me any specific points by which you can assess the patient in your clinic to decide the best vascular access?
So in the clinic, I will examine his non-dominant hand and I will examine his arterial pulses as well as using a hand and Doppler. However, this patient will need a formal arterial duplex anyway. I will first take a history of this patient and see if he's got any comorbidities, if he's smoking. I will examine his pulse and his blood pressure. And after getting a duplex done, I would make my further plan with regards to his management.
Okay. Could you tell me some of the complications that can occur with vascular access?
So the complications that can happen is Steele syndrome. It can get stenosed. Risk of aneurysm. And ischemic mononeural neuropathy, something of the sort.
Yeah.
So these are the complications.
I attempt that myself, but yeah. Fine. Now, those were the main questions that I'd written. So I'm just going to go ahead and discuss.
Yes, please. Yes, because I've just told you some bullshit.
No, that most of it was right. The good points you mentioned were non-dominant arm, distal as possible. The preferred or the first commonly done fistula is radiocephalic, so radial artery cephalic vein. And the second point being distal is the snuff box. It's not common to find enough vessels to get a good fistula in the snuff box, but if that's possible, then that's next. So usually radiocephalic, and then going more proximally to brachial. To start off with the questions, so first was, so that covers the preferred vascular access, and you mentioned the other points about the size, etc., which was right. In terms of the assessment of the patient, it's more of the anatomical assessment. So it says assess the chest, neck, and upper limbs carefully. Look for any either previous fistulas or previous surgeries in any of these areas, or anything, any burns, so any scars, basically, that's going to hinder your access.
Yeah.
And after that, the most important thing is obviously check the vascular patency. So you're checking both arterial as well as venous patency as much as you can. So it mentions specifically an Allen's test, which you can do in the clinic to assess the palmar arches, etc. And so that's the thing. Along with, obviously, it needs to be supplemented, as you clearly mentioned, by a Doppler to assess what the final status is.
Yeah.
That was clinic access. And complications, I think, again, for the sake of this exam, is just to try and make it more systematic into immediate complications, which are the usual bleeding, aneurysm, all that stuff. And then, so basically early complications and late complications. So you mentioned Steele, thrombosis, stenosis, and the last one, which I'm not going to attempt. But other than that, obviously, the important ones are also bleeding. And the only other question will be, how do you manage the complications? So any ideas? The common complications are thrombosis, stenosis. Steele is also, it mentions, relatively common. I'm just trying to find my notes. Give me 1 second. There, got it. Right. In terms of access, also the types, do you know any of the types of the fistulas that you could create?
So I only know the anatomical types of fistulas that as you said, radiocephalic in the snuff box, and brachiocephalic or brachiobasilic. I don't know.
Yeah. So the other thing I'm asking in terms of other than non-dominant and location is basically you're going to do an autologous arteriovenous fistula in which you're going to obviously just anastomose directly. It could be a graft between the artery and the vein. So that's the second type, arteriovenous graft. And the other forms of access apart from fistula is you're going to discuss, say, tunneled central lines.
Okay.
So these are the three main things. And in general, to think about the pros and cons of each is, one, the timing of the access. So if you need emergency access, there's no doubt about it, you need a tunneled central line. So someone who, like in our ITUs, crash and needs filtration, you're going to do it through the central line, or of course, if it's going to be more long-term, tunnel central lines, etc. Those are, of course, more chance of complications occurring in terms of all the hemothorax, pneumothorax, all the lung complications, bleeding. Long-term infection is a problem, and obviously change of lines. Coming to grafts are the advantage of grafts versus autologous veins is you can use the grafts faster, as in within few weeks they mature.
Yeah.
Whereas for the autologous primary arteriovenous fistulas, you need to allow 6 weeks for them to mature.
Okay.
So that will depend on how soon your patient needs the renal replacement therapy.
Okay.
So these are the things to assess in the clinic. Apart from, I guess in this, it's more specific, like the patient probably is quite morbid. He's probably sick. You're thinking of someone who needs dialysis.
Yeah.
But your questions were right in terms of history, which could suggest problems with vascular access, like smoking, diabetes, hypertension, anything that could say peripheral vascular disease. In terms of assessment, so chest, breast, upper arms, pulses, and neck also for any previous access in the neck, previous central lines used in the neck, because anything that's done more proximally is going to affect your future access distance.
Okay, got it.
So that's right. And in terms of size number, it says more than 2.5 millimeter or greater is the preference for the vein at the point of anastomosis, and 1.5 to 2 for the artery.
Okay, got
That's what it mentions here in companion.
Sure.
So those are the main things. The other complications. So basically, they ask these are some of the questions in the book. What is early failure? What is late failure? So early is usually it's classified as within 3 months.
Mm-hmm.
And there could be problems with either the artery is already atherosclerotic, so you have a bad artery, or during the creation of the fistula, you can tether or kink or apply tension on the vein distal to the fistula, and that leads to outflow problems. These are the two common early failure reasons. Late failure is similar in terms of stenosis, atherosclerosis, and thrombosis. And most of these you can attempt percutaneous angioplasty to correct, but if not, if the fistula fails, then you either have to redo it proximally. In case of early problems of thrombosis, then you have to do a re-exploration and try to reattempt the fistula. And you mentioned steel, and otherwise, I think, yeah, we've covered this part of it.
Thanks, Senthil. That was a masterclass.
Oh, no. I literally just went through it yesterday to try and not look like an idiot myself.
Prashant, the one thing which I want to add is, so which is preferred mode of anastomosis? Is it end to side or side to side? So any idea about it?
I think it is side to side, isn't it?
No, it's actually, I think it's end to side.
End to side.
I think they
end
prefer
of vein to side of artery, right?
Yeah, artery, end of the artery to the side of the vein.
To side of artery. End of vein to side of artery.
End of vein to end to side artery. Okay. And regarding this, this is ischemic monomelic neuropathy. I think that is the ischemic monomelic neuropathy, and it is, as it is a neuropathy, it is more common in diabetic. I think that's.
I think that's more of part A question.
Yeah, it was, yeah, more of part A question. I was a bit like I was revising brushing up my mind, recollecting whatever the Senthil was saying, and more important in the what I felt like in the examination, clinical examination, I felt Allen test is more important, which you must. I think that's very very important, isn't it? The Allen test is more important. Otherwise, I think it was okay. Yeah, Allen test.
Yeah.
And Senthil, I think you have picked up all the whole of the things. I don't think you missed anything. Earlier versus late. I feel like this should be a general concept. When they ask for complication, just open your mouth saying early or immediate complication, late or delayed complication, so that we can slowly pick up things from one by one.
Yeah. True. No, I had absolutely no clue of this topic, and now thanks to Senthil, I don't even have to study it now. But there's
no need to study. He has covered everything. And he
Yeah.
has covered everything. And I think only one thing which he has missed is how to deal with the complication of Steele syndrome. I just had a look at those things previously, revising all those things which I studied for part 1. Pi procedure, drill procedure.
Yeah, each complication you have to just know, I guess, the specific thing. I mean, if you're going to have a Steele, the general.
Just a second.
response is
I think Amar is
Yeah.
waiting. He's not waiting in the room. Is he waiting in the room? Sendil, can you check? Is
I've
Amar?
got. Oh, yeah.
He's waiting in the
Okay,
room. Can you make me host?
Yeah, I've admitted all of them, but I'll make you back the host. So. Right. How do I make you the host?
I think I claimed my host, and
Good. Yeah, it says you're the host already.
Is Moses? This is Moses. Is Amar? Are you here? Are you in, Amar? I think he's in, Amar. Amar?
Shall I just discuss the next one? Or
Host not allowing unmute. Okay, yeah, just a second. Ask to unmute. Just a second. Who's make a co-host? Yes.
Guhan, when is your exam?
This week, Thursday and Friday.
Thursday and Friday. Good luck. Where is it?
Sheffield.
Sheffield. Okay. Nice.
You're giving in September, isn't it?
Yeah, September in Cardiff, and it's only HPV. So.
Oh, okay, that's.
So I chose that option. So no upper GI.
Okay.
Hopefully that was a sensible decision. I'll find out in September.
Yes, of course. I think upper GI is like vast, and you have to study upper GI, HPV, and all the things.
Yeah, of course. I mean, if you have to study, it shouldn't be a problem. But it's just that now working in HPV in UK, then you know at least one part of the system.
Yeah.
And generally MDTs and all that helps with this exam. So anyway, I'm attending the upper GI MDT as well, just to keep in touch.
Okay. Yeah.
While you're waiting for it sorted out, the only other thing in fistulas that the questions are fistula surveillance and how important that is. So it says regular surveillance and assessment in the clinic. If there's any problems with the fistula, then you can assess with the Doppler. And it says that the flow rate is generally between 300 to 600 ml per minute, and anything less than 300 ml per minute is an indication for investigations, because that could predict imminent thrombosis. Okay. And like Varun was saying, for the Steele phenomenon, the the funda is that you'll have to end up with probably a ligation to avoid the distal ischemia. And some of these procedures that are mentioned with either plication or ligation is basically, one is called distal revascularization and interval ligation. That is the drill. And the other one is a revision using distal inflow. So that's known as RUDI, RUDI. Otherwise, I think if you just mention that it requires ligation, that should be part of it.
Sure.
And the next scenario was just basically to discuss brainstem death, prerequisites for testing, confirmation, and apnea test, types of donors, and contraindications. So that's it. That will be the next 5-minute thing. Which I think if everyone's happy with that, then we can either skip it or do it for the sake of discussion. Or did you do any of the courses, Guhan?
No, actually, I didn't have the time to do.
Yeah.
Okay.
Thank
Mm. Neither did I.
Okay. Yeah, I signed up for the Alpine FRCS. It's in September.
Well, that's nice, actually.
Well, I was hoping to go to the Alps, but this one's in Manchester. So,
are you in?
Yeah, I can hear you, sir. Thank you so much.
Oh,
I
okay.
can hear you. Sorry
Amar,
about that.
we just killed our some bit of time.
No,
discussing something.
No, you were doing liver transplant. I heard that.
No, we just we had one Viva session from Sendil. Very nice topic, and we revised everything. I think Prashant will be extremely happy with that.
Yeah.
All right. Amar, what are you going to start with, Amar?
All of you guys are doing next exam. Who is doing the exam this month?
Yeah, this month.
Anyone or
the 3 people those are going to
join. Yeah.
Sorry, you're saying something?
Amar, you want to start? Who's going to take up? Is Guhan or Prashant is going to take up?
Can I take?
No, if you want to do a colorectal, like it will be like we can do like for a colorectal exam. Those who go for a colorectal exam, because they will ask a bit deeper, isn't it? If you go for a colorectal, if you are a colorectal FRCS, you're going for the colorectal exam, it will be better for them to take it up because they will ask you a little bit deeper in that. In HPB, it will be different. So,
Amar, it's okay, Amar.
It's okay.
What we need is
we'll start. Okay,
just,
that's fine. Sure.
Just a bit of exposure to everyone.
Oh, okay, that's fine. Sure. So we will start with a normal setting. Is it all right? Okay. 7. Is it who's doing it? Guhan?
Yeah, I'll do.
Yeah, sure. So 75-year-old man comes in the 2-week wait clinic with the history of change in bowel habits. So how will you proceed and manage this patient?
So I will take up a focused history and clinical examination. And I would ask about his altered bowel habits. How long is he having it? And I'll ask about his bowel habits and is he having any loss of weight, loss of appetite, any bleeding per rectum? Is he having a melena? And is he having any vomiting symptoms? And is he having a spurious diarrhea? These questions I'll be asking him. And then
he gives history of changes in bowels with constipation for the past 2 months, history of bleeding per rectum for the past same time. He gives history of tenesmus also, in case you've not asked it, which is a feeling of incomplete evacuation.
Yeah.
And also he gives history of loss of weight and loss of appetite. So those
Yeah. By this history and with his age, I'm thinking of malignancy here. Most probably a left colonic or a rectal malignancy. So further, I'll be asking him about his past medical conditions, and is he having about his comorbidities, and is he on any medications, and about a family history of malignancy. And I would be asking about the performance status as well. And going on to the clinical examination, in the general examination, I'll be looking for anemia and any generalized lymphadenopathy. And in the abdominal examination, I'll be looking for masses in the abdomen and any hepatomegaly and any shifting dullness or fluid in the abdomen. And I'll go on to the rectal examination and with proctoscopic and rectal examination.
Okay. Proctoscopy, you're able to find you're able to feel a growth about 6 centimeters from the anal, but you're not very sure. So how will you proceed now? Abdomen is soft, not tender, nothing else is seen on abdominal exam.
So in the perectal examination, I think this growth would be at the tip of my finger. So I'll be just assessing the mobility of this tumor, and also is it circumferential, is it stenosing? These are the things I'd be looking for. And then I would go on to investigate him further with blood investigations. And I'll be asking for a full blood count, urea and electrolytes, liver function test, INR, and also tumor marker, CEA. And I'll be asking for colonoscopy and to look at the entire colon at the tumor as well, and to take biopsies from the tumor. And the extent of the tumor, I'll be doing a colonoscopy. And then I'll be discussing in an MDT. I'll be doing staging investigations as well. So in the staging investigation, I'll be getting a MRI of the pelvis with CT chest abdomen and CT chest abdomen and with MRI of the pelvis. I'll be doing, and I'll be having a look at the biopsy as well.
Okay. So what are any other investigations would we be doing? Would you do tumor markers and things like that?
Yeah, I'll be getting a CEA level.
Okay. So what are you basically looking for on the MRI scan? Basically, how do you classify rectal cancers on the MRI?
So on the MRI, I'll be looking if it is a low tumor, or so it's 6 centimeters from the anal wall. So what I'll be looking at is it a low tumor, or is it a high tumor? Is it above the peritoneal reflection or below? In this case, I assume it's below. And I'll be looking at the extent, and then I'll be doing a T staging based on the MRI. So is it extending into the mesorectum, and looking at whether any mesorectal nodes are there, and is there any vascular invasion, extramural vascular invasion, and I'll be looking at the circumferential margins if they are threatened, and and any other lymph nodes outside the field of the mesorectum, like iliac nodes or anything that also I'll be seeing on the MRI.
Okay, how will you classify on the MRI? Do you know this T staging, or how will you classify tumors on the MRI?
Yes. So basically, T1 is basically it's a mucosal and submucosal cancer. T2 is infiltrating into the muscle. On T3, it's going outside the muscle. So based on A, B, C, A is up to 15 millimeter. Sorry, 5 millimeter. 5 to 15 is B, and beyond 15 is C.
No, I think A is less than 1, B is 1 to 5, C is 5 to 15, and D is more than 15.
Okay.
So A is just 1 millimeter from the muscle wall. That's A.
Yeah.
B is
Yeah.
1 to 5, C is 5 to 15, and D is more than 15.
Okay.
Alright, so that is D, and then you have a threatened margin. As it goes closer to the TME, it's a threatened margin and then involved margin. What is basically the difference between threatened and how much is it from the margin to call it a threatened margin?
If it is less than 1 millimeter from the circumferential margin, that is the visceral fascia, then it is threatened.
Okay, so this tumor is actually a T3. This is involving. This is up to within less than 1 millimeter from the CRM. So they consider it as a threatened margin. So
Yeah.
what would you discuss it in the MDT, and how would you proceed further? What do you think will the MDT decide basically for a
the
tumor with
MDT
a threatened
in
margin?
this patient,
And he has a couple of nodes also, which are like N2 nodes. So what would they decide on the MDT?
in the MDT, I think they'll be going for a long course chemo radiation therapy, which involves like 50 gray of radiation over 6 weeks with chemotherapy as a radiosensitizing agent. Yeah.
What is a chemo? Okay, that's fine. So they give chemotherapy and thing. So how long would you wait after you give long course chemo radiotherapy?
Ideally, I would wait 6 to 8 weeks, but now there's evidence coming up that even if we wait longer than that, then the tumor regression is better.
So they say 8 to 12 weeks now. The longer, the better, as you say. But
Yeah.
12 weeks is usually being taken as a limit. So so you're giving chemo radiotherapy. How will you assess for the response?
So after the completion of chemo radiation, ideally before I take up the surgery, that is at around 6 to 8 weeks, I'll be doing a MRI of the pelvis again to look at how the tumor has responded, whether the margin is still threatened or has it shrunken, and what about the nodal status, and everything I'll be reassessing again.
Okay, so when you reassess the tumor, you find that there's a complete radiological response. Okay.
Yeah.
So if there's a complete radiological response, what are the options that are available? Would you still offer surgery, or are there other treatment modalities which you would like to offer the patient?
Yeah, so I would be discussing with the patient that there are various ways of dealing with this. One is even if there is a complete radiological response, but pathologically we are not assessing it. So, so one curative option is to proceed with surgery, that is low anterior resection with a covering stoma. And the other would be wait and watch policy. So since there is a complete radiological response, we can check with a endoscope as well, or rigid proctoscopy. We can check how the mucosa, and if there's complete response, we can keep the patient under surveillance. Ideally, it should be like in the initial year, it should be 3 monthly scanning and scopy.
So so complete. How long will you do it if the patient wants a just a conservative, just wait and watch approach? So how will you?
We can. There is evidence for up to there is complete response in up to like 40% complete response, but among that, more than 50% recur. So, if the patient recurs, then they'll be going for a salvage operation.
Yeah.
So as long as the patient recurs, I'll be keeping under surveillance.
So it requires, so we are basically following the HePAR-Gamma approach, isn't it? So that was done by HePAR-Gamma in Brazil. So they give clinical, radiological, and endoscopic surveillance. So they first, the index thing, they do a biopsy. They do and the biopsy should also show tumor regression. Show tumor regression. So there should be absolutely fibrosis with no evidence of malignancy. So after that, there are various protocols that are being followed. So, I mean, they will not be expecting you to know, because in the UK also, it's not very established. Some of them follow with various protocols. So but it should employ all three: clinical, radiological, as well as endoscopic surveillance at various intervals. Yeah,
Yeah.
and the salvage for it is definitely surgery. Yes.
Yeah.
So, what do you know about TME?
TME
What is
is
TME?
total mesorectal excision, and it is popularized by Professor Heald. And usually we take the entire mesorectum along with the fascia up to the levators, and usually this mesorectal fascia is a condensation of the visceral fascia. So we go between the pelvic and the visceral fascia and do a complete mesorectal excision. This the benefit of this is that it reduces the local recurrence and um, uh, and better oncological outcomes.
So overall survival is much better, and it's about 80%, and the local recurrence rates are very low, like 4% from about 30%.
Yeah.
So that is the advantage of doing TME, isn't it?
Yeah.
So what you said, you'll offer a covering stoma for all patients. Is it like all patients you'll use a covering stoma? Is it?
So if it is a low rectal tumor, especially there are various factors in which I will consider a covering stoma. These factors are low rectal tumor, previous radiotherapy, obesity, and male with a narrow pelvis. And intraoperatively, I'm not satisfied with the anastomosis. There was a leak that I have taken a stitch, and in all these cases, I'll cover with the stoma.
Okay, so that is all right. So if for example it was so this is a tumor which is at about the lower limit is about 6 centimeters from the anal verge, all right? So so you're planning an anterior the lower limit. So now, for example, if the stoma, so before that, what is the role of short course radiotherapy? When would you offer short course chemoradiotherapy? Short course radiotherapy.
Short course radiotherapy is ideally we give for 5 days of around 25 gray, 5 grays a day, and then operate within a week. So wherever I'm aiming at a quick surgery, like I'm going for primary first approach and then going for a liver resection, or in these sort of cases, there is opportunity of short course radiotherapy, but right now it's not being favored in the UK. So for tumor downsizing, the better is long course radiation therapy.
So short
course is best to sterilize the field and
it reduces local recurrence rates, but it is not curative in the sense that it doesn't downstage the disease.
Yeah.
So that's the difference between short course and long course. All right. So after that, what are the so for example, if this tumor is say about 6 centimeters, less than 6 centimeters from the anal verge, so how would your treatment modalities vary? How is it different? Say it is about 3 centimeters from the anal verge.
If it is at 3 centimeter from the anal verge, in that case, in the MRI, I'll be looking for sphincter involvement and whether it's involving the levators. And these are the things I would be looking for on the MRI and the nodes as well. And if it is a primary anal, is it a primary anal canal tumor going to the rectum or the rectum to the anal canal? Because if it's an anal canal tumor, then its treatment is going to be completely different with chemoradiation therapy as a primary modality. So, and is it a adenocarcinoma or a squamous cell carcinoma? If it's a squamous, I'll be going for a primary chemoradiation therapy as the definitive manner.
Stick on with the rectal carcinoma involving the anal canal. Okay.
So
if it's about 3 centimeters from it's involving the so it's a rectal carcinoma. The lower limit is it's from about 3 to 6 centimeters from the anal verge.
In that case, I'll be assessing again, going for a neoadjuvant long course chemoradiation, and then I'll be restaging for any metastatic disease, and then going for a abdominoperitoneal excision. And to obtain a good margin, I would be going for a ELAP sort of procedure, where I take a cone of a cylinder of levators along with the mesorectal fascia in order to not cause coning of the waist of the specimen.
So what is a Quincke score? A Quincke score? Do you know what is a Quincke score that they use it for a specimen?
Yeah, I think it is for to find out a defect in the mesorectal fascia. It's
basically
a
for
pattern.
completeness. Yeah, for basically completeness
Okay.
of the specimen. So you have
Okay.
1, 2, 3. It's just a visual representation of the completeness of the specimen you get in APR. So where
Okay.
3 is a completely perfect specimen, which looks like bilobar complete excision, to 1 is a very poor specimen excision. That means that you have left something behind, doesn't it? So
Yeah.
what are the advantages of an ELAP over an APER?
In APER, usually the specimen gets coned at the waist, that is at the level of levators. So there is a possibility of circumferential resection margin positivity. So in ELAP, we go for a cylindrical excision. So taking fat along with the levators, with the cuff of levators, and with the mesorectum, so it all forms like a cylinder, and the circumferential resection margin positivity rates is less. But the downside is that we might have increased perineal complications, and sometimes, most of the time, we will be able to close, but sometimes it requires a flap for reconstruction as well.
Yeah. So, and specimen perforations, not only the CRM rates are higher, the specimen perforation rates are also higher, like about 50, about 50% higher in APER, whereas in LAP it is about 10% specimen perforation rates. They are like 20% in APERs. Okay. And the perineal complications are also double. You can just remember it's just double. So the perineal complication rates are nearly 40% in LAP, whereas it's only 20% in APER, whereas this is about 20% in. So you don't need to remember the percentages. Basically, APER has got twice the amounts of intraoperative specimen perforation, whereas perineal complication rates are only 1/2 in APER. But the specimen complication rates are very high in LA, isn't it?
Yeah.
What do you know about sphincter preserving surgeries for lower rectal cancers?
So the sphincter preserving operation is where in very low rectal cancers where it is involving the internal sphincter, but not the external sphincter. We can go for like intersphincteric resection and preserve the sphincters. This enables maintenance of continence, but it is the downside of it is the low anterior resection syndrome, where the patient has like increased frequency, at least in the immediate up to 1 year, where the bowel movements is like 6 to 8 times, and gradually as the patient adapts, the frequency might come down, but some go on for years like that.
So there are actually 3 types of intersphincteric resections. One is a total intersphincteric resection, where you do it at the intersphincteric groove, that is almost near the anorectal verge. Then you have a partial intersphincteric resection, where you do it at the level of the dentate line. And then you have the other one, you do it between the dentate line and the intersphincteric groove. Yeah. So these are the 3 types. But as you said, the recurrence rate, the functional outcomes are very poor. Sometimes people prefer rather to have a stoma rather than going for a intersphincteric resection with a coloangioplasty.
Yeah.
So what is the role of endo ultrasound in these patients? No, just generally endo ultrasound in a patient with rectal cancers as a staging modality.
I'll be using endorectal ultrasound in case of early tumors. Ideally, it's T1 tumors or to differentiate T1 from T2 tumors. In T1 tumors less than 3 centimeter in size and well-differentiated tumors, we can go for local excision in the form of TO or TAMIS surgery. And so in order to assess whether it is a T1 or T2 tumor, and also if it has got nodal spread, endorectal ultrasound is a good modality.
Yeah. So basically to see whether it's a T1 or a T2, and for low nodal involvement. Yeah. So you said about TO, TAMIS, TEMS. What are they basically? What is TEMS? What is TAMIS?
TEMS is it's basically the platform differs. So in TEMS is both involve microsurgery through the anal passage, and in both our microsurgery involves local resection of the specimen to full thickness with adequate margins and to close the defect. It's basically a local excision technique. Both are microsurgery with the platform inserted through the anus and with
Basically,
laparoscopic.
the difference is in the platforms. In say TEMS, you use a BUS scope, which is a specialized scope with instruments. Whereas for TAMS, you use basically a gel foam port, which you put it in the anus. So basically, you use the same instruments that you use for my minimally invasive surgery here. Whereas for TEMS, you use a specialized BUS endoscope, and then you do the surgery. So that's basically the difference between it. Yeah, so that's fine. So what are the, how will you, if you have a suspicious lesion in the liver, how would you investigate it further? You have a carcinoma rectum with a suspicious lesion in the liver. How would you investigate that further? What are the further, how would you investigate? The
So
CT shows
I'll
a
be
suspicious lesion in the liver.
Yeah, I'll be looking at the tumor CEA, and then I'll be going for a MRI liver, and also I'll be doing a PET scan to investigate this more.
Which has got a better sensitivity for a liver metastasis.
It is MRI liver actually.
Okay, MRI than a PET scan.
That PET scan sometimes may not light up, but MRI liver is like really sensitive, and based upon the various sequences, we can characterize the lesion better.
Okay. So actually, MRI, they say it's about 75%. FDG PET is 90%. We're having a higher sensitivity, but the specificity is lower, isn't it, for a PET scan? So the MRI is more preferred, that's what they say.
Yeah.
So regarding clinically, I think, is it like time up, or do we have to go further?
Go ahead, Amar, no problem. Go ahead.
Okay, so we'll just go a little bit. What do you know about TNT? Do you know?
TNT is
COVID times.
TNT is total neoadjuvant therapy. So there is this Rapido trial which has shown that giving totally neoadjuvant upfront chemotherapy with it's a total upfront chemotherapy, and the regression rates are better, and instead of usually in the long course neoadjuvant treatment, we don't give the full dose of chemotherapy. It's just a small fraction of the chemotherapy, basically radiosensitizing agent that we are giving, and total chemotherapy we give it after the surgery. But in this Rapido trial, they've investigated like giving the chemotherapy upfront, because in advanced tumors, it basically the cancer is a systemic disease. So in order to treat that early, they go for total neoadjuvant therapy and have shown better regression rates with total neoadjuvant therapy.
Yes. So basically what we do, as you said, after surgery, you again give another installment. Basically what they say is that in patients, especially in the COVID times where you couldn't do surgery and patients had a long waiting time, it's better to give chemotherapy. It does not include only chemotherapy, because you have chemotherapy and radiotherapy also. So you give chemoradiotherapy the full dosage, and they found out that it's got very good, or in fact sometimes better in some of these trials, better disease-free survival and organ preservation rates than the traditional neoadjuvant followed by surgery. Yeah. So I think that's good. So basically for rectal cancers, I don't think they will do so much, but this will be at least some part of it. I think you did very well. I think especially, but when you examine, just mention supraclavicular nodes usually. That's the only thing that I could really, that too, if you have to look with a lens basically to find some things. But otherwise it was very good. I mean, others can answer if they want.
Thank you very much.
Super, go ahead. Superb.
Thank you.
Gohan, just please mention about the previous endoscopies and colonoscopies. Amar, I wanted to ask you something. Is a FlexiSig with the CTC is okay, or are we supposed to do a colonoscopy when there is a rectal tumor?
I think the rectal tumor is basically you have you not only you do a colonoscopy for synchronous lesions, which are about 3 to 5%.
Yeah.
So the problem is you can do a CT colonogram with a FlexiSig, but of course, if you are going to find something, you again need a colonoscopy. So
Yeah.
if you do go directly for a colonoscopy, you will obviate the need for a CT colonogram in the first place. So that's the rationale. Of course, in an elderly, very sick person who cannot tolerate a colonoscopy, a FlexiSig and a CT colonogram can be a reasonable option.
Okay, but will there be any issues in the tumor when we put in the colonoscope and meddling with the scope to reach the cecum? Will there be any issues happening? Will there be any complications of the rectal tumor when we do
Unless
the
it is
colonoscope?
unless it is a concentric rectal tumor, almost perforating, it is difficult to
Reach the cecum.
Yeah, it is difficult to cause complications in the sense.
Okay.
What are the rectal, unless it is a concentric rectal tumor where you cannot pass in the first place, I don't think you will have much of a problem. But of course, the benefits overwhelm the risks also, in the sense that if you have a synchronous lesion, then you can get biopsies also of that, and you can plan something total, isn't it? If you have, say, a cecal malignancy, a polyp or whatever it is. So
Okay.
that's the
there is a question which I was like someone asked me some question, like if there is a distal polyp and a proximal tumor, for example, there is a right-sided tumor and you notice a 2 centimeter polyp in the left side or in the sigmoid or in the rectum or whatever, are we supposed to remove the polyp before the surgery or after the surgery?
It depends whether it's a 2 centimeter polyp, because it all depends on the site of the tumor of the polyp, its relationship to the primary tumor in question. If it is in the same field, like if, for example, it's a cecal tumor with a transverse colon polyp, then anyway it's going to come with the specimens.
I'm very clear now.
Yeah, very clear.
The
Left
tumor
side.
is right side.
Yeah.
The polyp
So the
is
first
sigmoid.
thing is, where exactly is it? Is it if it is in the sigmoid, if it is amenable to polypectomy, of course you can try a polypectomy and do a polypectomy before the procedure. But if you don't do it before the procedure, at least you should do it after the procedure within a year, within 6 months to a year. So that's a guidelines, isn't it?
One of the trainer he said that not to remove the polyp because there any chances of seedling of tumor on the raw area after we do a polypectomy before we treat the primary?
I actually don't know about that.
No,
but,
even I was surprised. Like this is a rare possibility, but they don't. The reason what they said is they don't want to remove the polyp, and they want to remove the polyp after the right-sided treatment. So, like they remove the primary, and then they do a polypectomy immediately after the patient recovers from the surgery. But
Yeah,
they
you
say,
can do it,
what they say is seedling.
Yeah, there is a theoretical possibility, but in that case, it should be done within a time period. I think at 6 months to 1 year, they have a cutoff, isn't it? So within
they said it's a cutoff that like 3 weeks, 3 months or something.
I think it depends on the size of the polyp, because if it's more than 1 centimeter and turns out to be high grade or containing an invasive component, then obviously it needs to come out before the definitive surgery. But if it is less than 1 centimeter, the chances of malignancy and high grade component is less. And then this patient will undergo a surveillance colonoscopy 6 months to 1 year anyway.
Yeah.
Okay, so thank you. All right. Anything else?
Just had one question and one comment. Very well done, Gohan. At the point of, say, assessment in the clinic of this patient, where you mentioned that proctoscopy or rectal exam showed a 6 centimeter tumor, is there any role for early biopsy? Of course, after safety netting consent, making sure it's safely possible. Is there a role of biopsy at that point?
If it's an anal tumor and easily accessible, I think we can do a biopsy. But if it's a high tumor, like 6 centimeter, we are taking a biopsy and it bleeds. So in that case, I think I would go for a colonoscopy, but I don't know if it is the right answer.
Okay. Just wanted to have Amar's opinion as well on that.
Yeah, I think it's a fair enough answer. If it's you can say it like if it's accessible and there's no harm in getting a biopsy. The word access, patient comfort are paramount, isn't it? So if you can,
absolutely.
So if access and patient is it's comfortable, then you can try. But anyway, you're going to do a colonoscopy, so you might as well get it at that time too. So there's no harm in saying, provided it meets these two parameters of accessibility and patient comfort.
Okay, thanks. And the second thing, more from a general point, was when we discussed treatment options. Guhan, like in this case, when he mentioned there's complete response, what are the options? Try to lay out all the options in a neutral manner, because if they're assessing the way you're discussing it, if you say one is this is the curative option, whereas the other one is you're already favoring one when you're telling the patient. Like I have a consultant who very commonly when she's counseling for hemorrhoid, she goes, the two options are stapler and open. Stapler is very good, it's very quick, there's no pain, whereas open is painful.
Yeah,
so she's already
it's a good way. That's what I told last time also. When you discuss the options, just give a bird's eye view of all the options available under the sun, and then go to what you would prefer with the pros and cons of each. I think that would work out better because the examiner, it's basically an exam where the examiner wants to check your knowledge within a definitive time frame. So if you lay it out on the table, it becomes far more easier for him or her to assess you and just tick boxes rather than you saying this. And maybe because in the exam you have added factor of tension and other things. So it would be better if you can give the options out. I understand that there is a role for this, this and this, but I would prefer this because of this and this. Something like that. So that it becomes very clear for the examiner also.
Fantastic. Okay, shall we go to the next one?
Yes.
So you want me to do one more? Something about upper GI?
Upper GI, yeah.
Something, all right. Hey, who's
Is it okay, Amar? Have you got time?
Yeah, I'll do one more.
All right. Amar, what I can say is just if you, it doesn't need to be like, Prashant, are you okay with this? Like, it doesn't need to be like an exam. Just then and there to correct things. It will be easy for the for us to get it corrected then and there rather than
waiting till the end, isn't it? Like
till the end,
that's fine.
Is that okay, Prashant?
But if one person can answer, it will be better because it will be faster. So for
no, Prashant is going to be the candidate. You are going to be the examiner and things. Okay.
Sure.
Okay.
That's fine. All right. So shall we start?
So
it's a 72-year-old man comes to the A&E with your ST6, you're the consultant, the ST6 calls that the patient is having hematemesis. So he's asking you to come to the A&E to evaluate this patient. So how will you proceed? 76-year-old with hematemesis.
So I'll go to A&E and I'll assess and resuscitate this patient in tandem. I will resuscitate this patient according to the CRISP protocol, and I will have a look at his airway, breathing, circulation. We'll start him supplemental oxygen. We'll establish 2 whiteboard angios, take some basic blood assays, laboratory assays, send off his group and save clotting, as well as take a lactate. If he's bleeding too much and if he's clinically unstable, then I would have a very low threshold of activating the major hemorrhage protocol. And at the same time, I would I will insert a catheter and monitor his urine output.
Sorry, what is this? What is a major transfusion protocol? Can you tell me a few words about it?
So the major transfusion protocol is when we don't have the leisure of time to cross-match a patient, which takes 30 minutes. So in this case, we have group O negative blood, 4 units, which are 4 units. 4:1. 4 units available. And then we can activate a second one, which will have 4 units of O-neg with 4 units of FFPs and 1 platelet.
Okay. Carry on, please.
Yeah, and I'll take a history of this patient, starting from the onset, duration, progress of his bleeding. If he has had this in the past, if he's on any medications, any anticoagulation, whether he's a known case, whether he's been taking NSAIDs for a long time, and for what indication. I'll also see if he's on any PPIs in the past for any peptic ulcer disease. I'll ask and elicit history for loss of weight or appetite in the recent past, which was unintentional, and I'll take his any comorbidities or surgical history that he must be having, and then I'll continue resuscitation and reevaluating this patient after a fluid resuscitation. Yep.
Okay, carry on. Carry on to the examination.
So I'll examine this patient. First of all, I'll watch for signs of whether he's pale, dehydration, if he has got any supraclavicular lymphadenopathy. I'll examine his abdomen, look for any palpable masses or ascites, or if there are any visible veins. And then I would proceed to do his proceed to see and assess his inguinal region. Watch for to look out for any hernias or any previous surgical scars before. And yep, that's it.
Okay. In examination, especially in upper GI bleed, would you look for any stigmata of liver disease, liver failure, things like that?
Yes,
Why
yes.
is it important in that case?
It is in liver failure. Then it is possible that he may have developed cirrhosis and portal hypertension secondary to cirrhosis, and he may have esophageal varices or gastric varices, which may have bled. So it's important that we look for stigmata of liver failure in these patients.
What are the stigmata that you're looking for? Generally, from head to foot, what will you look for?
So I would be seeing for spider nevi caput medusae, starting with jaundice, any PR bleed, tremors of flapping tremors.
Okay.
Yeah, that's all that I can remember.
Yeah, gynecomastia.
Gynecomastia, yeah.
Ascites, testicular atrophy. I mean, in case you want to mention, that's yeah. So after that, what else would you do? So you have now done the hemoglobin. You have done the hemoglobin. The hemoglobin has fallen from a baseline of 150. It's now 100. He's using a 2 or a 3 though. So how will you manage him now? What else will you do for him medically? Would you do anything else?
So I'll have a look at his clotting and see if his clotting has been deranged, and see if he's on any medications for his anticoagulation perspective.
There's no history of any anticoagulation at the moment. There's no history of anticoagulation, and INR is normal. Coagulations are normal.
Okay. In that case, I would ready this patient for an endoscopy, for an urgent upper GI endoscopy, and then to assess where exactly is he bleeding from. And
on an endoscopy, if you are the endoscopist, what will you be looking for?
So I would be looking for any esophageal varices or any ulcers and bleeding ulcers that are that can cause this bleeding, potential bleeding.
Okay. So you find what is the most common cause of upper GI bleeding? Say on about 100 patients, which is the most common cause? It's more common.
The most common cause would be bleeding ulcer, a bleeding peptic ulcer.
Yeah, a bleeding peptic ulcer is even more common, even in a. That's the first thing that you should suspect, isn't it?
Yep.
So you do an endoscopy, you find an ulcer, the D1, from the D1 posterior wall, you find a bleeding ulcer. So how will you manage this at this junction?
So posterior wall of D1 ulcer would be classified as two of the classification. I forgot the classification, but yeah,
Forest. It's
forest
classification.
yeah, two
Yeah,
of the
so
forest classification. And I would first manage this ulcer endoscopically, and first I would be giving high dose PPI intravenous infusion, and I would then manage
sure.
and try to arrest this bleeding by endoscopy, and that would mean a combination of the techniques like clips, thermocoagulation, or even vasoactive injections.
So you basically do dual, isn't it? It should be
Dual.
dual. One is thermal and another is a non-thermal method. Or one is a mechanical like clip, or you can use a vasoconstriction like pharmacology, like adrenaline for vasoconstriction. Yes. So what are the classifications? That's forest classifications. What are the types? Do you know the types of bleeding?
Types
they wouldn't
of?
ask it if you aren't an upper GI, so they wouldn't ask the types and all.
So sorry, types of?
The forest classification. You said it's a type 2. Because you said type 2, I'm asking what are the other types?
Yeah.
Usually they don't ask this.
Yeah, so type 1 is an active spurting spurter vessel, which is pulsating. Then type the next type is an oozing bleeder. That's 1A and 1B. 2A is an adherent clot, and 2B would be the one with hematin on the clot. I think that's the one. And 3A is with a clean ulcer base.
I think it's 1A and B, and then you have 2A, B, C, and then you have 3. If I'm sure that's the thing. And type 3 is a clean ulcer base. Okay, so that's the importance of type 3. It's a clean base. Type 1A and B are, one is a spurting hemorrhage, the B is a oozing hemorrhage. Type 2 is divided, as I told you, into A, B, and C, where A is you have a visible vessel, B is adherent clot, as you said, and C is hematin covered lesion. So basically why we should know is that type 1 and type 2A and B have a higher chance of rebleeding. Whereas type 2C, that is the hematin covered lesion and a clean ulcer, the chances of rebleeding is very less. So this is basically to prognosticate about who has a higher chance of rebleeding. So for whom you should have a higher sense of a higher threshold to go back with an endoscopy, isn't it? So that's basically why it is. Anyway, so you have done that. Now you've sent the patient to the ward, and you get a call 6 hours later saying that the patient has had another episode of hematemesis and he's bleeding, in the sense there is blood in the tube, and his hemoglobin levels, which were stable at around 100, have now come to 78.
Right. So
he's
I would
losing a 5 now.
Okay. I would again reassess this patient and start simultaneous resuscitation. And while I'm doing that, I will again list this patient for a repeat endoscopy procedure. And while I'm resuscitating him, and while he's on high dose IV PPI, I'll take him back to the endoscopy suite to reassess the situation with the bleeding, offending bleeders, and we'll again try to address the problem with dual therapy.
Okay, so again you go back in. It's a type you put in a couple of more clips. And then you use your thermal thing. You coagulate it. Use a heat probe, coagulate it, and then you come back again. It looks like the bleeding has stopped. Now, would you give any specific advice to the nurses on the ward or to monitor him for? Any specific advice at this juncture, which you would like to monitor them? Like, what would be like? Would you say about vitals monitoring? What would you like? You be your post procedural advice?
Post procedural, he should have at least half hourly regular OBS monitoring along with an urine output, and he should have regular laboratory assays at 4-hourly interval, and to have a very low threshold to again re-intervene if his hemoglobin drops. He should be nil by mouth when he's there in the ward, and he should be continue to be on high dose IV PPIs.
Yeah. So your nurse is very faithful. She does whatever you say, and she's found that the hemoglobin is again falling after 4 hours. So this is the third, basically the 2 times he's already had an endoscopy, and he has had heat probe and adrenaline and things done. Now, how would you proceed? Again, he's bleeding. His hemoglobin is now, it's similarly at 80, but again, there is fresh blood in the endoscopy.
Yeah.
On endoscopy, how will you proceed now?
So unfortunately, this is not being addressed by endoscopy or minimally invasive endoscopic methods, and this will need a surgery at this point because there's failure of two endoscopic procedures. I'll explain that to the patient, and I will involve my critical care physicians as well as the anesthetist and theater staff, and I will tell them that this patient would need to come to theaters for a surgical management of a bleeding duodenal ulcer.
He is using only a two. Would you consider any other method, any other procedure before you consider surgery? Would you consider angioembolization? Is there a possibility where you could do that?
If this patient is stable, which it seems like he's using only a tube, then yes, that is an option, and we can embolize the gastroduodenal artery, or more specifically, the vessel which is arising from the gastroduodenal artery, which is bleeding. However, if he's clinically unstable and there have been a failure of two endoscopic managements, then this patient will need to go to theater.
Okay. So you've spoken to your radio your radiologist, interventional radiologist. Unfortunately, they are not on call. So, and he bleeds more. He's using number 5. You decide to take him to theaters. So, can you take through the steps of how would you proceed with the surgery, please?
Sure. After checking the consent and the site of the surgery, after doing the WHO checklist, I would prep this patient from his abdomen to his groin. I would make a midline laparotomy incision, and I would do, and as you said, this is a D1. I would do a longitudinal anterior duodenotomy, and I would have a look at and identify the offending bleeder ulcer. I would take two U stitches on the superior as well as inferior aspects of this ulcer using O vicryl. And then I will approximate the ulcer edges together with the same vicryl. If this doesn't stop the bleeding, then I may have to take the gastroduodenal artery when at its origin or entry into the pancreaticoduodenal complex. And if this has a this usually solves the and arrests the bleeding. At this point, then I will close the duodenotomy transversely. If this is an ulcer, I will also take biopsies of this ulcer before I close it. And if this ulcer, if this patient has had a history of peptic ulcer disease in the past and he was stable during the surgical procedure, I wouldn't mind doing a highly selective vagotomy at the same time. However, if the patient is not, if the patient is unstable, then I would leave it for some other time and get out as soon as possible after leaving drains.
So in this era of anti-ulcer medications, do you think a highly selective vagotomy is necessary?
Maybe not, but if he's already been on PPIs, high dose PPIs prior to surgery, and he has had a bleeding ulcer, then while this patient is stable, then I wouldn't mind.
So anything else would you like to do before? So so you said you would ligate it. You ligate the bleeding points. Would you do like a 3-point stitch, or how would you ligate it? So usually you ligate it at 3 points. Is it the gastroduodenal and the transverse pancreatic at one side? So we do a 3-point ligation, a figure of 8 stitch with the delayed absorbable suture. Vicryl is fine. O vicryl is okay. Some people use silk, so that's personal preference. Anything else would you like to put on? Would you put on a nasogastric tube beyond the ulcer to feed, things like that?
Yes, I would do. I'm sorry, I missed that. So I would place an NJ across the ulcer so that I can start feeding this patient. However, as this incision has been clean and the duodenotomy is not as a result of perforation, I expect it to heal, without any complications.
Sure. So you do. So you send the thing for a biopsy. What are you looking for basically in the biopsy?
I'm looking for malignancy because that would change the management, the further management of this patient, and Yeah.
Duodenal ulcers, mostly. What else? What else are you looking for? Anything else on the biopsy?
I would also look for if there is any evidence of if there is any pathological evidence of Zollinger-Ellison syndrome or gastrinomas, because this can also cause ulcers secondary
But
to
how will you
hypergastria.
how will you look on the biopsy for that? No, how will you look for evidence of Zollinger-Ellison on the biopsy? No, I asked you, would you look for, how would you look for Zollinger-Ellison? Okay.
Yeah,
How would you
I
look
mean,
for Zollinger? If you're suspecting Zollinger-Ellison, what will you be doing? Or what will you be looking for?
no, I think unless
Gastrin levels, isn't it? You'll be looking for gastrin levels, isn't it?
gastrin levels, yeah.
Yeah. So how much more? Yeah, sorry, carry on.
Yeah, sorry. In addition to gastrin levels, I'll also be looking for any evidence of H. pylori. Sorry, I missed that.
Yeah. So basically, you're looking for H. pylori.
H. pylori, yeah.
That's what you're looking for, H. pylori. So what are the ways of H. pylori testing?
H. pylori testing can be by a rapid urease test or breath test, and by biopsies, which is the histological gold standard. And
you can also use culture, but it's not being done.
culture, yeah.
It's also and then you have serology and a fecal stool antigen test also. So in the exam, you can say it is like invasive, non-invasive, and you can say these are the invasive, these are the non-invasive. So basically, they're looking for some structure. If you give a good structure, they wouldn't ask anything more actually, isn't it? So they expect kind of a structure. If you say it's invasive, non-invasive, 1, 2, 3. And which one will you do for eradication? It's mostly the breath test that you look. I mean, that is all that they would ask. So coming on to, you said about Zollinger-Ellison. So because you said so, how will you investigate if you think the patient has got Zollinger-Ellison?
Yeah, I've dug myself a hole here now, isn't it? So
no, it doesn't. It doesn't go. It isn't bad because you say some things like that. It can work out well for you too.
So Zollinger-Ellison syndrome, I would look for, this is a functional neuroendocrine tumor of the pancreas, and I would look for the Zollinger, the tumor which would be located in the gastrinoma triangle, which is the superior border would be the cystic duct, the inferior border would be the angle of D2 D3 junction, and the medial border would be, or angle would be, the junction of the neck and body of the tumor of the pancreas. And more than 80 to 90% of the tumors are situated in this. However, I can also diagnose a gastrinoma by doing fasting gastrin levels, by doing a secretin test, because in a secretin test, normal G cells are suppressed by that. However, gastrinoma G cells are not suppressed by the secretin test. And
so if your gastrin levels are say 1200, would you do a secretin test?
No, I wouldn't, because that would be diagnostic of
isn't it?
Yeah.
It's between 500 to 1000, then you do a secretin test. Otherwise, you don't need to do it. If it's over 1000, it's diagnostic. So basically, gastrinomas, you have a biochemical and a radiological. You do the radiological diagnosis. To radiological, basically to localize it. So how will you localize a tumor? Do you have any specific radiological investigations to localize a gastrinoma?
So we can use functional scans to identify a gastrinoma, which can be
what's a scan called? What's an SRS? Is that what you're saying?
Somatostatin receptor scintigraphy.
Yeah. So basically, it's got good sensitivity.
Yeah.
To localize gastrinomas. Yeah. So which is the more? So what is the malignant potential that you're looking for in a gastrinoma? What is the malignant potential in a gastrinoma as compared vis-a-vis insulinoma?
It is higher than an insulinoma. Most of the insulinomas are benign, but gastrinomas and glucogonomas are more malignant than compared to insulinomas.
Yeah, that's fine.
Yeah, and they mostly metastasize to the liver and lungs. Yeah.
Okay. So that's fine. Okay, that's fine. So familial gastrinomas, oligorelicins, they might ask you in case they go in, but usually they wouldn't go so far. I think it was very good, actually. It was very good. I must say that because I don't think they will go this far. But remember in the exams now that with the COVID exams, as I've done, because with the COVID exams, what's happened is it's very easy to give you a picture of some rare condition and ask you to say what it is. So without the COVID test, what happened is that you would spend more of your time in answering the patient, making them feel comfortable, asking questions like that. Now without the patient, now all the time is there for the examiner to ask questions. In a way it is easy, in a way it is difficult. In the sense, now they start giving you photographs. All that they need is to give you a rare syndrome which is connected with, say, a hereditary colorectal cancer, something like that. They can give you a physical manifestation or something and ask you questions based on that. So actually the scope is more wider. But if you can answer it, it's very good, because then it obviously puts you on a better plane than compared with others. So that's what I would say, is that the question range will be wider, because in the COVID exams, because there is not much of physical examination or anything to go about, and the examiners have a lot of time. But otherwise, I think you did very well. That's all. It is very good. The flow is very good, and I don't think you'll have any difficulty.
Thank you so much. I just wanted to ask you, since you mentioned it, since the COVID times, because there are no patients. However, I've also been told that one of the examiner acts as a patient, and we have to consider him as a
But that's mainly for consenting, because the examiners, you can't examine the other patients. Imagine there's another examiner sitting. He is going to play the role of a patient who you tell something regarding consent, mostly like explain how you would consent it to a layman, and that patient would behave like a layman. Sorry, that examiner would behave like a layman, and he would say, oh, what do you mean by a stoma? What do you mean by this? What do you mean by that? So he's going to play the role of a patient. It wouldn't be more like examining an examiner, because he wouldn't play the role of a patient in any case.
Okay.
In the sense like a clinical exam, isn't it? Is that what you're asking?
Yep.
Yeah, he wouldn't. You can rule that out, because no examiner likes to be touched and examined and palpated. So I would suggest that rules it out.
Amar, I just wanted to ask you something. Prashant, you said about when you approached the A&E, you said CRISP. Is it CRISP or ATLS protocol? I was just confused in that area. When you started, you said
I think it is. I'm sorry. I think it's ATLS, not CRISP.
Okay, because I was just confused with that when you said CRISP, because this is purely hematemesis.
Yeah.
And Amar, do you want? Is it mandated to check for the signs of liver failure in any patient with hematemesis, like ascites, jaundice, spider nevus, and all these things?
Sorry, I didn't know. I didn't realize I didn't have the video on. Sorry. So 20% of the times, hematemesis is due to liver causes.
Okay.
So you should ideally be looking for. It shows the examiner that you're thinking that 20% of the times hematemesis can be due to a liver cause. So it helps you, isn't it? So I would suggest you say it up front, because examiners would know then that you have thought about liver causes. It's basically telling the examiner that you have thought about these things, and it's basically a question of letting the examiners know that you know well in advance.
Okay.
Thanks.
The risk stratification in the beginning, Glasgow Blatchford score, I think we should start it immediately when you face a patient in the A&E, because it's very important to know where are you going to put the patient in the ward, in hypervigilance unit, ICU, and also when will you do endoscopy, after 1 hour, 2 hours, 3 hours? According to the British Society of Gastroenterologists, I think within 24 hours. I think so. I'm not in UK, but I know.
No, if regarding endoscopy for a patient who is in hematemesis, if the patient is unstable, this patient has to be transferred to the urgent endoscopy in 6 hours time, And if the
Yeah.
patient is stable and if the patient can be resuscitated, the patient has to be having the endoscopy in 24 hours time. In the next endoscopy list, this patient has to have the endoscopy. Prashant, you are okay with the resuscitation part. Amar, I just wanted to know, is you were asking about the interventional radiology, and I think Prashant was saying exactly, because there is a drop in hemoglobin. When there is a drop in hemoglobin in a patient who had 2 episodes of drop in hemoglobin, and third, should we go ahead and talk to the radiologist at that moment, or should we warn the radiologist about the second, when the patient had the first drop?
Basically, you don't know whether the patient will have a rebleed at the end of the first thing. So you take it as it comes, isn't it? So there is a higher chance of rebleeding if it's a Forest 1A, but that doesn't mean that everybody will rebleed. So what is the point in talking before a rebleed happens? That's one. Second thing is, I would say, and you don't know when the rebleed will, in case it happens. So I don't see any reason why you should talk before. But of course, when it happens and after a rebleed happens, now he's had the second is also a rebleed. You've tried and you couldn't. The options are embolization vis-a-vis surgery. So all I say is that you include it also in your treatment paradigm, so that you show that you know that these are the options available.
Okay.
Discussing with the radiologist at the end of the first, usually we don't do, because most of them, a large proportion, I think 90 to 95 will be 2 endoscopic procedures are enough. So that's why we don't talk to the radiologist, because there is sufficient evidence to show that only a very small minority will go to a third rebleed. So if you start talking at the end of the first rebleed, you obviously have a large proportion of patients for whom you will have to speak with the radiologist, and they won't be happy also.
And regarding the PPIs, are we supposed to
give an infusion,
infusions and a high dose of PPI once we see the patient with the hematemesis, or
we don't know, isn't it, if it is due to varicose or whether it is due to if you know very well that it is due to if it is due to peptic ulcer, then you can start PPIs. But sometimes you don't know, it can be varicose, because then you need to start telipressin and things like that, isn't it? So once you know after the endoscopy, then you have a Bombay protocol where you give 80 milligrams, I believe, IV bolus followed by 80 milligrams over a period of 8 hours. So some protocols with a loading dose and with a continuous infusion.
I think it's a Hong Kong protocol, right?
Hong Kong, sorry, not Bombay. Yeah. Something, yeah. Oh, sorry, it's 80, isn't it? 80 milligrams, I believe, bolus.
Yeah, it's 80. Yeah.
Okay. Just these are the things which I had in my mind. Prashant, can you tell me what you were saying, something about massive transfusion protocol? You were saying something. I'm not aware of that. Like, is it the first instant is O negative blood, and then second instant is 1:1:1?
Yeah, so this is I read Upper-GI quite a while back, so I wasn't actually quite fluent with it. But as much as I remember, the first part of that protocol, you just get 4 bloods. When you ask for the same patient, you ask for it again. You have 4 bloods, 4 FFPs, and 1 platelets.
Yeah. So it is like you give it in 2 installments. You have a part A and a part B. So when you have a massive blood loss, this varies from trust to trust. Some have different protocols, but this is the most common thing that's followed in our trust, where you have a part A where you can avail up to 4 units of O negative bloods, which can be transfused at any time. Then you have a part B where you can have 4 units of FFP, 4 units of packed cells and platelets. So, but it varies from trust to trust. So I think you can just say what you follow. I think that's more than enough.
Okay. All right. Any other discussion? Any other doubts or anything?
I just had 3 or 4 questions and points. One, I think at the point of resuscitation in A&E and decision taken to go for endoscopy, then you have to involve the critical care team there itself, even if it means just post-operative care. This is ideally a patient who's going to go, even if it's just for observation, to critical care. So not at the point of rebleed. Usually these patients, if they go for an urgent endoscopy, are going to come back into the HTU at least for observation. It's easy to say when you're observing, but I think you covered everything else really well and fluently. So that's great. One doubt I had is you had asked about the NG during surgery, but what about NG at the point of seeing this patient in A&E? Do you recommend it or not? I know it's a debate. So
I think it is at the time of bleeding in the A&E, because then you can evacuate the clots as well as bleeding, and the patient cannot then vomit and cause aspiration pneumonia. This is what I think, but I forgot to mention it. But I think Amar might have something different to say.
Yeah, I think an NG tube makes more sense, isn't it? It makes more sense, provided the patient is compliant. Yeah, it makes more sense. Definitely, you can say an NG tube because it's better to say it because you lose.
Yeah, I think probably better to say it. That the only other school of thought is that putting an NG may cause a patient to retch, increase pressures. Potentially, the NG may, if it's variceal bleeding, cause disruption or rupture and cause further bleeding. So that's why sometimes if you're going for an urgent endoscopy, they'll say you put it under endoscopy vision after. That's 2 schools of thought. Third thing I wanted to ask you was regarding the infusion for the PPI. So here, I think in UK, it's the Hong Kong protocol and infusion, but actually World Surgical Gastroenterology has actually moved on to BD bolus or stat doses. So it will be 80 milligrams BD rather than an infusion. They've study shows it's the same outcomes whether it's infusion or whether it's BD. And if it's infusion, it's usually 72 hours, and I think they monitor. And the last comment was, I think it's doubly or very, very important to assess history of cirrhosis, whether it's history or examination, because like he said, the management changes for giving terlipressin, vasopressin, which itself reduces bleeds, reduces rebleeds and mortality. And if you're able to do that, then it may potentially improve the success of your endoscopy also, because you may end up finding something that's stopped bleeding rather than something that's still actively bleeding. So I think assessment for cirrhosis / peptic ulcer is of primary importance even while resuscitating the patient.
Okay, thanks.
Thank you.
Is there any role for UNEs elevated, and if there is any chronic long-term bleed? Is there? I'm just checking. I'm just asking you. Is there any role for like neomycin?
So that's what Dr. Abdu mentioned about the. You're asking about the UNE. So the Blatchford score is the objective assessment of whether this patient, if it's someone in the ward who bleeds, or if it's a new patient, the assessment how much they will require an endoscopy reintervention or not, and that is they take into account basically your hemoglobin, urea, shock, and there's 2-3 more parameters.
Okay.
That's the HUSP score or Blatchford score. And in terms of other scores, there's also a Rockall score, which takes pre-endoscopy and post-endoscopy criteria to assess the morbidity mortality.
All right. Okay.
Whether that needs to be mentioned in the exams, because I unfortunately haven't read about it.
No, I think, see, unless they ask you particularly the score, I don't think it needs to be mentioned. You're covering it in your fluency. You've covered it in terms of you've said, send the bloods, look at this, I'm looking at the blood pressure, thinking how unstable the patient is. It's a matter of sometimes in these exams, they are asked, it's like a P-possum score. I mean, you can clinically assess the patient and say this patient's fit for surgery, or you could put a P-possum and label it with a score. It's the same funda. I mean, if you have a score that says so much, if the Rockall score is above this much, then it's on paper to say that, yes, this person needs an endoscopy rather than your clinical opinion. So it's just objectifying it, but I don't think it's going to, unless they ask you, I don't think you really need to mention it.
Prashant, I think
bonus points.
Good, actually, you crossed more than an hour, probably. I think more than 40 minutes. You will not be asked 40 minutes. I think it's just 20 minutes.
Yeah. Thank you very much.
Yeah,
Thanks.
I think they wouldn't expect you to know the scores per se, and but some of the examiners, they might, as a matter of interest, they might ask you. In which
Okay.
case, if you answer, it is very well and good, but they wouldn't usually so. But I would
Okay.
suggest that if you know, it is better to say in the exam,
Okay,
because
I'll read about it.
anything helps you. So I would say.
Thank you.
Thanks, Amar. Thanks a lot.
Thanks so much. Is it all right?
Thank you.
Thank you.
Sendil, do you want to continue or shall we do it on some other day?
Anything, whatever is the general consensus.
We
I-
have 20 minutes. We have 20 minutes. I think we can do that. And 5 o'clock we can finish.
Sure,
Yeah,
sure. It's two very simple scenarios. That's all.
Sorry, guys. I have to go. See you on another day.
Okay, Gwen.
Yeah.
See you. Bye-bye. Thanks, Gwen.
Yeah.
Sendil, do you want to,
Yes.
what are the scenarios which you have?
One is regarding brainstem death and the discussion about that. And the second one is, bear with me 1 second. The other one is basically post-liver transplant management. So dealing with the complications post-liver transplant and management.
But Prashant, do you want to do anything? I think Prashant left. No,
Yeah.
Prashant is-
Okay, let's do it. Let's do it.
we can take a 2-minute break, take a breather, have a sip of Coke or something.
I'm good. Let's do it.
Okay. Yeah, I mean, it doesn't matter much of the scenario, but basically 45-year-old male, generally fit and well, road traffic accident, currently intubated, ventilated in ITU, suspecting brainstem injury. How will you proceed?
So, as a part of analyzing and assessing this patient for brainstem death, I need to see that all reversible causes of brain injury have been identified and ruled out. And this might include a barbiturate overdose or opioid overdose or respiratory compromise or ventilator malfunction. This patient needs, and after all these reversible causes have been ruled out, we need to have a look at this patient and confirm that he has a brain death or not. And this can be confirmed by doing a few tests. One of them would be after pre-oxygenating this patient for 5 to 10 minutes, and after seeing to it that his PaCO2 is less than 6.5 kPa.
6, yeah.
6.5.
If it's COPD, it says 6.5, but otherwise 6.
6.5 or 4.3. Yeah, we would disconnect the. First of all, I'm sorry, I'm jumping on. First of all, we would see whether his cranial, his function of brainstem by seeing whether he has a corneal reflex, by seeing if he responds to pain, by seeing a vestibulocochlear reflex, by instilling cold saline in his vestibule or in his ear, if he has got eye movements, lateral eye movements, to check for gag reflex and cough reflex, and to check if he responds to pain stimuli. And then we can, after pre-oxygenating him, we can disconnect the ventilator and see if he's got any respiratory movements for 5 minutes. And if he doesn't, then we need to reattach the ventilator, and he can be deemed brainstem dead. After these tests are carried by two medical professionals, at least one of whom is a consultant at 2 different points of time. And then he would be labeled as brainstem death. And the actual time of brainstem death is the first time the test has been conducted on him.
Right. Okay. So you mentioned about the 2 medical professionals. So can it be any medical professionals, people involved with the case? Is there there's one more criteria I'm looking for you to mention.
Yes, one of them, I'm sorry, one of them should be a critical care consultant, and the other can be a qualified doctor. And he may or he may not be a consultant. And
Okay.
And these two consultants should not have any vested interest with regards to his decision regarding brainstem death.
Okay. Just to make it difficult for you. So if I ask you tomorrow, if you are asked to certify the brainstem death, are you certified to do it? Basically, what I'm asking, there's just one criteria more, which is specific, is that they have to be registered for at least 5 years with GMC.
Oh yes, yeah. They have to be registered.
Yeah, that was the specific thing. Okay, so you mentioned about areflexia and the apnea test. Can I ask you, what are the prerequisites to certify brainstem death? So you mentioned about reversible causes. Is there anything else? And is there anything else before you decide this patient can be for organ donation?
So this should this should not be an unnatural cause of death, and it should be ruled out. The case should be forwarded to a coroner who will rule out any unnatural cause of death or any inquest in this patient's death. And once we are done with that, then this patient can undergo brainstem death testing, and then further decision for organ harvesting or not.
Okay. The specific thing is actually just the easier way out is to look if this person is registered as an organ donor with the NHS, and if he's registered, then your problems are sorted. If he's not registered, you may need to either do the consent or have someone do that certification so that you can take the organs. Okay. And the last question is, what are the types of organ donors?
So the types of organ donors are two. One is the two main cadaveric would be donation after brainstem death, donation after circulatory or cardiac death. There can also be altruistic donors and living donors.
Right. And could you mention a few more things about donation after cardiac death? Are there any types?
So donation after cardiac death would be types, you say. Well, it can be controlled or it can be an uncontrolled. According to the Maastricht criteria, it can be controlled or uncontrolled. And here in the UK, we do uncontrolled, isn't it? Not a control.
Okay. Yes. I mean, most of it is, I think, people in the ITU, which is controlled setting. Uncontrolled is Maastricht categories 1, 2, which is dead on arrival, failed to resuscitate, etc. Most of them are awaiting cardiac arrest, say in the intensive care and you're withdrawing support.
Yeah. Sorry. Yeah.
Can you tell me few points about contraindications of the organ donors?
So the contraindications can be, first of all, if it's an unnatural death, or if it's caused by violence, or if it's a homicidal case, then it has to be, or if it's a cause that is not known, then it has to be forwarded on. The case has to be forwarded on to the coroner, who may deem whether this patient can be eligible for organ donation or not. Secondly, if the patient has got any malignancies which may contradict his organ donation, and it can be any melanoma, glioblastoma, hematoma, untreated skin cancers or treated skin cancers within 2 years. If he's got any prion diseases like Creutzfeldt-Jakob CJB. And the other thing would be if he's got, however, this is not a strict contraindication, but if he's got any HIV.
Okay. And could you tell me any organ-specific contraindications, say for liver, renal, pancreas?
So if the organ itself is unhealthy, so in case of if the liver is itself cirrhotic, or has got any liver tumors, or has got any metastases, or has been injured during the primary trauma, then that would preclude its use for organ donation. And the same goes for kidneys. If the kidney has got any chronic kidney disease, stage 3, stage 4, or not reversible kidney injury, if the patient is diabetic, then that would preclude his pancreas. Or if there's any intra-abdominal malignancy or metastases to any of these organs, then that would preclude these organs for transplantation.
Yeah, that's right. So I mean, that's 5 minutes. So I think as far as the questions, that's what's these are the questions that come under brainstem death and types of donors, as far as I've seen. Do you want me to just discuss the points?
Yeah. Just I think to summarize, Sandil, I just wanted to ask you, is it okay to say the patient, because I've not worked in the transplant, I don't have any experience in assessing a patient for a retrieval or donor or whatever. The thing is, what I ask Prashant and you is it okay to say in the first instant that when I'm going to check for the brain death, I have to have a look at the notes and check, is there any contraindications for it? And is there any other things which is contributing to this brain death? I felt there is something called as hypothyroidism and hyperthyroidism or something which has to be ruled out as well. Check his blood.
So first of all, ethically, you should not be thinking of organ donation when you're certifying brainstem death.
Okay.
It is not. So you are thinking the patient has suspected brainstem injury and you're confirming it. Only the next step after that is to think of organ donation or not. Because otherwise, ethically, imagine you're managing a patient in the ITU GCS3 and you're thinking this guy's a potential organ donor. So that's where the ethical problem comes. Then
when the question is asked to certify a brain death, am I supposed to check the notes or not?
So the notes you're saying, or the nodes?
Notes. I'm saying the case notes, the files.
The case notes, yes, of course. I mean, as a part of the thing, like he mentioned, the critical points of certifying brainstem death is one, ruling out all reversible causes. So you need to assess on the notes if all reversible causes have been dealt with, mainly drugs, medications, hypothermia, and any reversible metabolic, endocrine.
And endocrine. For these things to assess, am I supposed to see the notes before I start the tests?
So the testing is then, so after you assess the notes and assess all reversible causes, only then you can go to the next step, which is areflexia.
Okay. So to start up with, it is better to say, before I'm going to approach the patient, I'm going to have a look at the notes to check, is there any reversible causes like whatever endocrine, metabolic, and new electrolytes and all this.
As well as respiratory causes as well. So basically, any muscle relaxants should all be stopped and rule out cervical spinal cord injury.
Okay.
So I think if you just mention, even if you say don't review notes, you say the first step is to rule out reversible causes as a general, and under that separate headings if you need to.
All right. Okay. And I think rest of the things went well. The sense like I'm happy that the tests and all these things. And just for a confirmation sake, I think, is it 25 mils of cold water or
15.
15.
50. 15.
50 or
50. 50.
Okay, so it is 50 ml. And is there any specific temperature? I think there is some specific temperature.
Ice cold. They said ice cold.
Ice cold, yeah.
Ice cold. Any
0
temperature?
degrees. No, okay. 0 degrees. Ice cold.
0 degrees. Okay. And the next thing is, that's it. Is there any specific forms or anything to fill up in this process?
I mean, most trusts have it's like a checklist. So when you go brainstem death, it's more like a checklist to say yes, all reversible causes, and then it will be tick boxes to say all the areflexia, which is top to bottom, all the reflexes, so cornea, gag, including through the intubating tube, put the catheter. So look for any reflex gagging, and motor responses, of course, starting from top to bottom, supraorbital pressure. So they'll generally have a checklist, and then for the apnea test also on the forms, usually it will be timing, first apnea test, who's conducting, all those things. So I don't think there's any other specific
So is
form
it how
that
many apnea tests you should conduct in general? Like, is it 2 apnea tests?
two.
Okay. 2 apnea tests by one consultant, or 2 tests
No.
at different
Two
points?
different, out of which one should be a consultant, and as Senthil said, the other one should have at least 5 years of.
No,
medical-
I'm clear with that. The thing is,
Yeah.
two independent
Yes.
people has to certify it.
Yes.
Are they going to do 2 independent apnea tests?
Yes.
So this has to be done twice.
Yes.
Okay.
The duration is usually 6 hours apart, but as I've learned recently, there is no fixed timing. The timing is for the patient to recover from the first apnea test completely, and then you repeat the test. So it may be few hours, it may be more, but it is just the time duration that involves the patient, because you're disconnecting the ventilator. Obviously, the patient, they're going to desaturate. There's going to be some form of change. So you are allowing them to settle again, and let the the ABGs come back to normal, and then you're doing the apnea test again. And basic fundamentals to look for hypercarbia, and in the state of hypercarbia, is there any respiratory stimulus? And if there is any, then you have to stop, abandon the test immediately, and continue to ventilate the patient.
I didn't know the exact figures, but I haven't done the transplant bit at all, and I'll revise it. Thank you.
You did well. I'm just checking the points which I read for the part 1. Is there anything which I'm missing, or which we want to learn something more about it? As you guys are.
So the only other thing is, in the contraindications part of it, a lot of them are gray areas. Like you mentioned HIV, but there are, there can be exceptional categories or extended criteria where you can give an HIV liver to an HIV patient, you can give a Hep C liver to a Hep C patient, hepatitis B also same. The absolute contraindications are like active infection, active sepsis, Creutzfeldt-Jakob disease, or anything related to it. To the extent it even mentions in the UK papers that if patients are from South America, Mexico, they can't be donors. People have received blood transfusion in those countries before, etc., unless you do, say, a negative antibody test, and that's proven that they don't have it. So stuff like that. But
Senthil, I think melanoma is definitely one of the strict contraindications, and so is a glioblastoma or something, right? That's an absolute contraindication.
Yes.
Again, primary glioblastoma and melanoma, yes, but then most of the others, say primary cerebral neoplasms, you can allow because it does not cross the blood-brain barrier. So they say that there should not be any transfer of malignancy.
Yeah.
Under melanoma, I'm not sure about it, but I thought I've read before.
There's a time duration. Yeah.
Actually,
more than 5 years.
And you're right, actually. It's 2 years, I think. It was
within 2 years.
Yeah.
Okay.
Any doubt? Anyone wants to add anything?
No, I think.
Yeah, and organ specific, you mentioned most of the things. Obviously, any active liver injury, trauma, any also problems with hepatic artery, portal vein, and for renal, other than chronic kidney disease, even if there's hypertension requiring 2 or more antihypertensives, that's also contraindication. And for pancreas, it is both age more than 55, obesity, and insulin dependent diabetes.
Okay, got it. Insulin dependent.
Insulin dependent diabetes. Those are the things.
Thanks.
Thank you, Prashant. Yes, and I'm the only one left out for transplant, but I'm absolutely no idea what's happening in the liver transplant or whatever.
We can just discuss it. I can just tell you the scenario.
Yeah. You can tell me the scenario. I'll do my best, but you can correct me as and when I do the blunders.
No problem. Fine. So scenario is 63-year-old male post liver transplant for hepatitis C with an ALT of 3,200, bilirubin of 78 on day 1. On day 2, the prothrombin increases 18 to 22 and ALT goes from 2,400 or from 3,200 higher up. So what is the differential diagnosis and the management plan?
So this patient, when I approach this patient, I will think of post-transplant complications in terms of arterial thrombosis. You said bilirubin of secondary bilirubin.
78.
So ALT is getting worse, but the
3,000.
ALT is getting worse. The bilirubin is still hovering the same side. But in terms of complication, I'll think of arterial thrombosis as a first differential diagnosis, and second differential diagnosis as a primary liver transplant failure or something. The liver has not worked properly after the
the term is non-function, primary non-function.
Primary non-functional liver. So these will be in my mind. So in terms of approach, I will immediately check for the resuscitate the patient with what is the coagulation profile you said about?
So the prothrombin time has gone up from 18 to about 22.
Okay, so it's still manageable. I'll check these signs of any bleeding or anything, intraabdominal bleeding or any forms of bleeding anywhere else. If possible, check with the hematologist to transfuse or make sure that the patient gets the clotting profile corrected if needed. Otherwise, I'll go ahead and investigate further to check for a clot or a primary liver failure. So to check for the clot, I think I have to do a CT, triple phase CT to check the arterial.
Is there anything that can be done bedside?
Duplex.
So that's the preferred option, first option.
Okay. So with that, if there is any kind of thrombosis in the anastomotic site, I think the management will be immediate to theater to. I don't know whether they prefer radiological thrombolysis. Is there any role for? I don't have any clue. But what I read about is like it is better to take him to theater to re-anastomose rather than any thrombolysis or anything.
Yes. Within first 3 weeks, it is an indication for urgent retransplantation, a HAT, hepatic artery thrombosis.
Okay. And in terms of the liver donor, we can ask for the patient or we can check is the donor available for the transplant purpose. Discussing the MDT.
Yes, absolutely.
And discussing the MDT to proceed further. If it is a primary liver failure, if I could not find any thrombus or anything, I have to think about the other possibility of primary non-functioning liver. So in that scenario, I will do a CT guided or ultrasound guided biopsy of the patient to put him in the transplant MDT and check whether we can, what could be the reason for the failure. And also check
what are the clinical features of primary non-function? So just think of any severe acute
primary, it should be actually jaundice, aside. Jaundice.
Hyperbilirubinemia.
Yes.
Jaundice
this
and
is the prime.
So encephalopathy, coagulopathy, sustained elevation of transaminases, acidosis. So those are the clinical part of it, and we do a biopsy, and that shows also obviously necrosis, hepatocyte necrosis. Then it's primary non-function.
Okay.
No. Primary non-function mainly hyperbilirubinemia in the first month, and it is not that common. So usually, sorry to interrupt you, but usually in that scenario, you should suspect solely vascular problem in post-operative day 1. Primary liver non-functioning, primary liver non-functioning is not that common, by the way.
Yeah.
And you shouldn't suspect it that early. It usually takes around 1 month to evolve and develop. And usually I see it as a hyperbilirubinemia only, nothing else. Just hyperbilirubinemia increasing, and we have no clue why it happens. So we do not know how to manage it, unfortunately. But the good news, it's not that common. It's rare.
Yes, agreed. It is rare. It is definitely rare in the first week, but I have seen it in the first 2 weeks of a liver transplant.
Oh, good. I haven't.
Senthil, I think I read about this thing, and there are a few questions in part 1 as well. Like if the CT doesn't show anything, any clots or anything, we have to think of.
Yeah, the first thing, like you mentioned, first priority is to rule out a vascular complication, which is mainly hepatic artery thrombosis. And don't get confused with stenosis. Stenosis is usually a later complication. Thrombosis is the main immediate complication in the first week, because in the books and sometimes MCQs you get confused when you see stenosis and thrombosis. But thrombosis is the first thing that needs to be ruled out. And if the thrombosis is ruled out, the next important thing to rule out is a biliary complication.
Okay.
Simultaneously, you need to check the immunosuppressant levels, which is also very important.
Okay.
Another important thing is to assess the operation, what's been done in terms of what is the biliary anastomosis, what is the arterial anastomosis, what was the size of the artery, what were the cold ischemia times, warm ischemia times.
Okay.
These are important because these are predisposing factors towards an initially poorly functioning graft. Or you can have a strong risk factor for an arterial thrombus or strong risk factors for primary non-function as well. These can be there. The clues can be in the history of the patient, etc. The donor, yeah, and the donor. Few questions is that the donor was it a marginal donor or not? That could be the main question, at least for this discussion point of view. So if the donor was a marginal donor, also there's a high risk factor for the graft function being affected. So
overall,
donation after cardiac death, usually you will see something like this, not after brain stimulus.
So overall, the approach should be like we have to check the operative notes and make sure that what are the things has been anastomosed. Was there any? What is the cold ischemia time? What is the warm ischemia time? And was there any issues in the? Is there anything called as end-to-end anastomosis, side-to-side? Everything is end-to-end anastomosis, isn't it?
Most likely, everything is end-to-end anastomosis.
Okay.
The bile duct will be either end-to-end bile duct or it will be a bile duct to jejunum. So hepatico-jejunous or choledochorigenous.
Bilioenteric, duct to duct or bilioenteric. Just two.
So the thing is, anyway, mainly post-liver transplant is hepatology management. So your surgeon's role as such should be if there is any surgical complication. So one is, like we said, hepatic artery thrombosis that requires reintervention. Biliary complication usually should be managed endoscopically, preferably. But if it is obviously a very severe biliary complication or a leak from a duct-to-duct anastomosis, you may need to re-explore to convert the anastomosis.
Okay.
And and the third thing is whether this patient is, for any particular reason, needs a retransplant, then you're going to come in as a surgeon to opine. So I don't think we need to go too much into the detail of the graft rejection and all that.
What will be the scenario if there is a biliary obstruction or biliary failure, like biliary obstruction? Like will there be increased ALPs and all these things?
It will be very similar picture of biliary obstruction. See, so the thing is, the problem is all these scenarios have a similar problem of deranged LFT. Whether it is rejection, whether it's arterial thrombosis, whether it's a biliary complication, they have a similar scenario of a deranged liver function. It's a matter of how much which is pumping.
Or viral infection like
or viral
CMV and
Exactly. Yes, that's why it's important to also optimize the immunosuppressant regime. See if the normal regimes are tacrolimus with steroids, and to see if the tacrolimus levels, what are they. So if it's over suppressed, you're going to end up with something like a CMV infection. If it's under suppressed, then you're going to end up with possible rejection, acute rejection. So those are the problems. So general assessment is one, rule out vascular complication. Two, think of biliary complications. You can do an MRCP to assess if you think, or you treat it like you normally would for any biliary complication. A CT, assess a collection if there's an obvious leak, drain, antibiotics. If you can endoscopically stent, then that's the best option. If you can't stent and you think you need surgery, then you need to. But you manage it as conservative as possible. If the patient develops a stricture, then you have to manage that accordingly.
Can you give me the time for
So-
arterial thrombosis is in the first few? It's like an acute episode.
Acute.
And what about the biliary stricture? What is the timeline for the biliary stricture?
So
Is it
can I say something? So exactly what Senthil said, but I've been working in this liver transplant unit for like nearly 5 years. So I'll tell you what we guys do. So transaminases in arterial in hepatic artery thrombosis will reach thousands. Okay. And the patient will be quite poorly, and you will understand that this patient has got a more serious problem than any biliary problem. The first step that we do whenever there is any case of raised transaminases is do an immediate ultrasound. Now, if your transaminases are in thousands, you don't need to do an ultrasound. You can directly go for a CT angiogram and find out that there is a hepatic arterial thrombosis. In that case, as what Senthil said, the patient needs to go to theater if it's immediate post-transplant. So early hepatic arterial thrombosis, I think 30 to 60 days. Different centers have different things, but this patient needs a resurgery or the graft is gone. And early hepatic artery thrombosis most commonly and most frequently because of a technical factor. So you first do an ultrasound if if you're not suspecting as a hepatic artery thrombosis, but you're still finding deranged transaminases and deranged liver function test. In that case, what you need to do is do an ultrasound to first rule out intrahepatic biliary duct dilatation. So that's how you rule out an anastomotic stricture, because in an anastomotic stricture, the ultrasound will show that you have got intrahepatic biliary ductal dilatation. Once you have ruled that out, then the third option, and the Doppler will also find out your hepatic artery resistance index, which should be more than 0.6 to 0.7. So again, that rules out your hepatic artery thrombosis as well as the stenosis. In a stenosis, the ultrasound Doppler will show you a Parvus-Tardis pattern, which is a radiological finding. The ultrasound Doppler will also rule out a portal vein thrombosis. Okay, so your hepatic artery thrombosis, your portal vein thrombosis, and your biliary ductal dilatation are all three ruled out. Now, the only thing remaining is a rejection. And that's why your transaminases as bilirubin has gone up. So when these three things have been ruled out, you then go for a biopsy in the same sitting, ultrasound guided liver biopsy. Then you get the biopsy and you take the biopsy to the histologist, who will analyze the biopsy according to BAMP criteria, which is PEP, which is histopathological grading. And they will also tell you whether it's a T cell or an antibody mediated rejection. If it's a T cell mediated rejection, you go for increasing your immunosuppression first by either increasing your prednisolone from 20 to 200, or if it's a quite acute and severe rejection, then you give IV methylprednisolone 1 gram. If it's antibody mediated, then your management is completely different and it can reach plasmapheresis and plasma exchange and whatnot. So this is post liver transplant complications in a nutshell and how to manage them.
Thanks, Prashant.
You just mentioned something. We stopped it now. The balsisteroid. You were talking about balsisteroid in a treatment for acute rejection, and it is not used anymore.
Sorry, what?
In the last, you talked about balsisteroid and treatment for acute rejection.
Yeah.
But I think it's debatable now, and there is a paradigm shift in the last year or something. We are going to stop it because of infectious complication and other complication, and it is not that good. Just you want to reassess the immunosuppression, increase it, and balsisteroid is debatable now. This is my talk.
Yeah, I get your point, but I think for the exam we will have to mention,
Yes, I know.
Prashant,
and we use because we used to do
Prashant, just to compare, just to sum up things, I just wanted to make sure. So if in exams, if we have any question like this, we have to start with ultrasound, and then we have to proceed with CT angiography, and then we have to proceed with an ultrasound guided biopsy. So that is the investigation line.
I'll tell you, the first thing to do is have a look at the bloods.
Okay.
Okay, have a look at the tacrolimus level of this patient. The tacrolimus level should be between, depending on the indication for transplant, but usually the tacrolimus level should be above 6 to 8, above that.
Okay.
Maximum can be around 11 or 12 also.
Okay.
Okay.
But in
So
the
if
second,
your
sorry,
tacrolimus level is
in the
low,
first day post-op, you cannot do it. We do it after 3 days. It is not reliable in the post-operative day 1. You cannot take
no,
any good information.
but you won't have rejection on post-op day 1. That's what I'm trying to say.
Yeah, I know. So
Yeah.
it's just vascular complication in post-operative day 1, vascular and vascular and vascular and vascular. That's it.
Okay.
Exactly.
Okay.
Yeah. So
Yes,
I'm just saying from the broader sense. So post-operative day 1, as you rightly said, you have to suspect a vascular thing. But usually on post-operative day 1 in the ITU, I mean in the UK and all liver transplant centers, we have ultrasound Dopplers in the ITU. So first you will find out what is your hepatic artery status.
Hepatic artery status, good.
Yeah, you won't have anastomotic, biliary anastomotic strictures on day 1 unless you have really closed off, you have done a shit job and you have closed off the bile duct. You won't have it.
Just the and one is
Yeah.
hepatic artery, two is portal vein. Thrombosis. And look at the ultrasound for these things and check the tacrolimus level. So can you tell us what is the reason for the checking of tacrolimus level?
So tacrolimus is a calcineurin inhibitor and one of the most powerful immunosuppressants. So we always use triple therapy, which is tacrolimus. The other one would be azathioprine or mycophenolate mofetil, and the third one is a steroid. Out of all of these three, the calcineurin inhibitor, which is tacrolimus, is the most powerful. And
so the reason for checking this,
it has to be in a level which will induce immunosuppression, and that level is above 6.5, 6.5, not even 6.5. Some might consider 6.5 is too low. Above 7 or 8, and the maximum can go to even 11 or 12. If your tacrolimus level is not within that range, that means your patient is not immunosuppressed. Again, I'm not talking about a patient who is post-op day 1, because for the first 3 days you will not have he will not have achieved the tacrolimus, and he may not even absorb the tacrolimus.
Okay.
Yeah. On the post-op day 1, ultrasound Doppler, and then if the ultrasound Doppler shows any problem with the hepatic artery, then go for a CT angio. That's it.
Okay, fantastic. So check for tacrolimus, do an ultrasound, and then CT angio, and then discuss the MDT, take up the patient for retransplant or resection. Take up the
I think for the exam point of view, for a non-transplant person, just need to know the terms: hepatic artery thrombosis, primary non-function. Just need to know that complications post-op can be arterial, venous, or biliary. That much is enough. And the fourth thing is rejection. Obviously, we're dealing with acute rejection in the immediate, but we just need to know the rejection types: accelerated, acute, and the chronic rejection, and just know the types. And we need to know some knowledge about the immunosuppressants, at least few names, and the basic regimen, like he said. So steroids plus induction agents, and then maintenance.
So tacrolimus, we start at 3 milligram twice a day. Azathioprine is 1.5 mg per kg, which is rounded off to the nearest 25. So it can be 100, 125, 150. And mycophenolate mofetil is usually 1 gram BD. Again, it cannot be given in pregnant patients or women who are planning a pregnancy because it's teratogenic. And while the patient is in ITU, he will be on hydrocortisone 100 milligram twice a day, which is IV. When the patient comes to the ward, he'll be started on prednisolone 20 milligram OD.
Okay, Prashant. Sendil, what is the next question? What can be the next question?
The last question is, bear with me one second.
No, you started with the scenario. I said the differential diagnosis, and I said this will be my management.
Yes. My questions were differential diagnosis and management plan. What is primary non-function, and what are the risk factors? How would you manage worsening liver functions? So indication for biopsy.
So the factors are immunosuppressants, not proper immunosuppressants, cold ischemia time, warm ischemia time, and improper.
And marginal donors.
What do you mean by marginal donors?
So basically, you have an optimum perfect donor, say a healthy young person, fit, well, liver, no problem, etc. That is your ideal donor I'm just very broadly generalizing. I'm not going into specifics. A marginal donor is one in which the liver may be steatotic, maybe a fatty liver. It may be a young or an old person, but a diabetic or obese person. Then it's that is one thing. It may be the ischemia times that make the liver marginal. So you'd have only warm ischemia times of usually 10 minutes, 30 minutes maximum. You won't have more than that. Cold ischemia times 8 hours at max. You won't have more than that. But if these are longer, then the liver it's a marginal. It's just a means of extending the criteria to whose liver we can take to transplant. Ideally, you take ideal livers, but because of the demand and supply, you're extending the criteria to involve people in which it may be 50-50 for usually a person who requires an urgent transplant.
Okay. So what is the next question now?
Yeah. So the next question is, how do you manage worsening liver functions, which I think Prashant has very, very accurately written about, like he mentioned, ultrasound, vascular, portal vein, biliary complications. You're assessing with one ultrasound itself, and if all these are normal, you're thinking about rejection, so you're doing a biopsy.
Okay. So
that's the general norm.
Okay. If the biopsy says, I think Prashant said that if the biopsy says any rejection.
Yeah, the specific thing is that Banff criteria. It's another thing to just know or note down is the Banff criteria, BANFF, which is what is used to classify the inflammation, the interstitial inflammation, and the tubulitis in the graft. And there's a whatever classification 1, 2, 3 based on that.
I think the Banff's criteria is also applicable for renal transplant as well.
Yes, as far as I am aware, yes.
Yeah, so I think it is applicable. Yeah,
it is applicable for any transplant then. Yeah. Because if I'm not wrong, I read this Banff's criteria only in the renal transplant saying tubulitis and vasculitis.
Yes, the same thing. It's interstitial inflammation. If it is mild, that is that first category. Second category is, as far as I'm aware, is severe tubulitis with or without interstitial inflammation.
Purely we can just analyze
theoretical, but just to know the term that is based on the Banff criteria, the rejection.
So my question is, so it is a general criteria for both liver and renal or any transplant transplant rejection.
I think so.
Because I read it in the.
It is, but I think the criteria may be different in renal from liver. We need to check that.
Yeah, I'm not sure about it either.
That's okay, no problem. Because I read it in the renal transplant, because when I prepared for my part 1, I read it in renal transplant, not in the liver transplant. Okay, is there any role for MELD in this? MELD or child books in this?
So that is all usually the pre-MELD is to assess end-stage liver disease to criteria to list for transplant. Any of these which go on to urgent transplant or retransplantation for all these reasons are usually, they supersede the MELD and they go on to your, what's it called, Prashant?
It is UKELD here, UKELD.
Yeah, here it's UKELD first of all, not MELD.
Yeah. Neither MELD and neither child PU. So we only follow UKELD.
It's only UKELD, yeah. But that once you become a supra-urgent transplant for a complication post-transplant, it supersedes all your other scores and criteria.
You mean to say that when the patient has got a high UKLD score, there is a high chance of post-transplant complications?
No, it's nothing to do with the complications. It's to do with the outcomes of the transplant. You're balancing survival of that patient without a transplant versus the morbidity and mortality of a transplant.
Okay, just to clarify things.
That's my understanding of MELD and UKELD. You're balancing out if this person doesn't have a transplant, what happens, what's his survival, versus if this patient has a transplant, what is his 5-year survival, morbidity, mortality.
Have influence on the post-op complications?
See, a person with a high MELD score or UKELD score is obviously someone whose liver is at the end of its spectrum of function, or it's not functioning. So it's a sicker patient, which means that there are possibilities of more complications, but I don't know what the literature says.
Okay.
And the last question.
I don't think there is. Well, a person with a high UKELD is obviously very sick, but that doesn't necessarily mean that he will have high complications. He's probably very sick from his liver disease perspective. However, the liver transplant will change the entire scene. Having said
Yes.
that, a perfectly well patient, probably, who's transplanted for HCC, might get a marginal liver and, may unfortunately have a complication from primary non-function. So these are
Yeah.
actually, we are comparing apples and oranges. So all
Yeah,
that the
yeah.
UCAL tells us is how badly the patient needs a liver.
Okay.
Yes.
Right.
It's
So-
only the criteria for listing.
Yeah. What is the last
Exactly.
question?
It is a
Senthil?
criteria for listing. So UCAL should be above 58 or something. 54
Yeah.
or 50. I don't know. 48 or probably. I don't know. I'll have to check now.
I think it's 40 something. 48 or
59.
something.
59.
59, sorry. 59, he said.
Last question.
Yeah. Last question is basically biliary complications. The only thing is to understand is one, the complications of strictures. Usually, like Prashant said, the initial part strictures unlikely unless you have a major technical fault. But the second reason for stricture could be the vascular complication itself. So the ischemia can lead to the stricture. So both components occur in the post-transplant for biliary strictures. It need not be an anastomotic stricture. The third thing is it could be a recurrence of primary sclerosing cholangitis for which the patient may have been transplanted. So there's three things to think about when you think of biliary complication and management. Is it anastomotic stricture, in which case you can stent across it? Does it need a revision of the anastomosis itself? And is it stricture due to ischemia, in which case your management differs? And if it's a recurrence of primary sclerosing cholangitis, then again your management differs. I don't think we need to go to the specifics of it.
I agree with you, Senthil. I don't think FRCS will go so much deep.
No,
unless
no,
it's
yeah,
a
yeah.
FRCS transplant candidate.
No, yeah, exactly.
I'm happy with whatever you guys said. I extremely happy that I just wanted to convey and learn what are the questions will be asked and how simple should we explain it. And without the background knowledge of transplant, liver transplant, renal transplant, all these things, we have to express our knowledge in a best possible simple way to show them that we know something. That's it.
I think less is more, and you can be honest and say, I don't have much experience in this matter, so I will, apart from doing my basics and looking at the patient, I will have to refer to a specialist center or consultant or MDT or take the help of a colleague. I think you have to be honest in these situations, whichever it is, whichever is out of this, scope of our understanding.
All right. Okay. Thank you, Sandip. Nice scenario. Simple, but plenty of discussion.
Yeah, transplant is a whole different ball game, isn't it? But on that note, my last question is, so if I'm applying, say, for HPB in part B, does HPB surgery involve transplant or not? I don't know.
So, transplant is different, and you need renal transplant numbers in addition to liver transplant numbers.
Correct. Okay. But so in my exam, say I shouldn't expect transplant except maybe as a rare clinical scenario emergency question or something. Not as a
liver
case.
transplant. Liver transplant. So whatever they'll ask you in HPB will be about liver transplant. And that will be pure basic. That will be at ST4 level, not ST8 level.
Yeah. I've heard. Yeah. So anyway.
Anyway, guys, thank you so much. It was really nice today.
Right.
It was really nice.
Thanks. Thank you, Prashant. Thank you all for attending. Please send us the feedback in the group. Thank you.
Thank you. Thank you very much. It was a very nice discussion. Thank you.
Thank you very much. Thanks.
Thank you. Drive safe.